And tonight with me in the studio I have a special guest, Professor Freddy Sengova from the School of Public Health, Makerere University College of Health Sciences. Welcome, Professor.
Thank you very much, and good evening, viewers.
Tonight we are discussing an important topic. We are going to talk about universal health coverage. We know that at least half of the world's population does not have full access or full coverage of essential health services. And it's going to be from this that we shall discuss further on what we mean by universal health coverage. Professor, you are the best at this. If one is to ask what is universal health coverage?
Thank you, Dr. Dung. As you started, it's about health, it's about rights. As you know, human life is very dignified, and we know that for any person, for that matter, any community or country, cannot progress, cannot live healthy, cannot be happy unless their health at the foundation is maintained in good health. So this universal health coverage is the new compact. It's a short word for how do we improve society or the health of people across the world so that no one is left behind. As you know, in this world we have so many different groups. Some are already enjoying fairly good living standards. Others are really not able to even get the basic treatment for simple ailments. But there is also this concept that we should keep much of the population away from needing care. So what the global...
What do you mean by that? Away from needing care?
Exactly. So when we talk of health, most people start thinking of hospitals commonly. But really health is how can you remain in a state of happiness, state of good health, where you do not necessarily need to come to a hospital, to see a doctor. And ideally that is the goal we need to be achieving. But should that health be impaired for some reason or the other, it's also important and imperative that you get the care you need. At that point then becomes care. But before that, we want to maintain people in their functional, good health, happy. And recently I was listening to one country, Bhutan. They measure their development by how happy people are in that country. It's not so much how many times they visit the hospital.
Okay. Yeah. So, you know, we have many people who, if unfortunately they have not been kept away from disease, they get disease.
Exactly.
And many of them find financial hardships. Yes. How do you relate to this?
So universal health coverage, or generally the goal, we call it goal number 3 in the new compact, which is currently called Sustainable Development Goals. Okay. Goal number 3 is about keeping healthy lives and well-being for all at all ages. And this is one of the equalizers, as WHO or World Health Organization has said, to try and ensure that we do not have to target this group or that group. We lift all up and ensure that all have good health. But should they get sick, the other tenant of universal coverage, the second tenant, is that they should not suffer financial hardship in the process of getting care. The third tenant is that the services should be available according to the needs. As you know, at different ages and different groups of people are going to need different services. Even as we grow up, at birth you need to be really taken care of as you come into life with your mom and all the process. As you grow up, you need a set of services. Of course, when you become also productive and have children, also another set of services. We grow up, and of course we die. And the process also of that, at that stage, you may need also different type of services. So how do we make all these services more available at the time they are needed, but not necessarily impoverishing people, but also making government aspire over time? And this is a very much an aspiration, so that they can aspire and they plan to make all these services available when required, and also not leave anyone behind.
Okay. Well, for some of you who have just joined in, this is UHealth, and I'm Dr. Dungu. Tonight I have Professor Freddy Sengova from the School of Public Health, College of Health Sciences, Makerere University. There's been a lot of confusion about universal health coverage, minimum health care, health insurance. How are these related? Are there aspects that one would not say actually are not universal health coverage, but they mean something else?
Yes, very nice. Thanks for that question. Clearly, universal coverage has been many times confused with other concepts. It's not, health insurance does not necessarily give you universal coverage. And I think the discussion here has sometimes confused the two. Because you can be insured, but doesn't mean that you'll get everything. Actually, insurance always gives you a package. They'll say, this is in, but this one is out.
Okay.
Meaning that whatever is out is not covered. But also when you are insured, doesn't mean that you are actually enjoying what universal coverage plans to, because it will not cater for your, most of the promotion services, keeping you healthy. You won't find it in the policy of insurance. Most of them will look for, when you get a problem, then you are entitled. If you don't have a problem, generally insurance does not come in. And that's where we have a big challenge to try and improve the promotion of good health within the programs of government, within communities, within our workplaces, so that somehow we do not have to, as I said, need care. And care comes in and insurance kicks in when you actually are sick. And it's important at that point to mitigate the costs, because then somehow you've put some money in the fund, they will cater for you part of the time, or at least much of the time. But as I said, it does not cover all the services. And as we increasingly see in our country, we need the services which people can't pay from the pocket. As you know, the poor really suffer more of the burden of ill health. And so even when insurance comes, you'll find that they can't actually able to participate unless there is some additional tools of government to give them subsidy or to pay for them to insure. So somehow insurance can work for me and you because we are employed, but those who are outside employment, it takes so long for them to get to participate. And sometimes you need economic growth first before more people can achieve coverage. So if we want to achieve coverage of any intervention in this country, the first thing to look at is what can we contribute within a community, government can put on the table in terms of provision. And of course, we know that health here is very much supported also by our external partners. And a lot has been done. Of course, we are not talking about a very new intervention here. It's building on the momentum we've been having over the years. And Uganda, currently we are somewhere. But of course, this is to aspire to actually do more and cover the ground.
You know, there's something you mentioned, us contributing towards.
Yes.
Many people have been imagining that it is the responsibility of maybe government.
Yes.
So actually, if we are asked to contribute, we can contribute towards universal health coverage, or actually it's...
As you know, me and you are the primary responsibility of our own health, just like any Ugandan. So if you don't eat well, if you go in, you entertain some lifestyles that are going to make you sick, we know smoking causes problem. We know, for example, unprotected sex, if you cross the road without following the road code, if you drive recklessly, all these are individual behaviors. So if you don't take responsibility as a person first, then you are making it very hard for you to be, and that's where we have to start. You have to start with what does individuals contribute to this program, and later we can see when individuals fail, communities, what can they do? If communities also fail, how can the broader government and the broader society of the world, the community, global community come into help? For example, now we have epidemics in Congo. There you will see that individual countries also fail. You need now the international community to act together. So there is a level at which others can kick in, but we need to first take responsibility. And at that level, many times money is not what we are looking for. All we are looking for are people aware. Have they been given information? If it's health education, do they have it? If it's about lifestyle, how to navigate, are they socialized well? Some of these cultures we have can be very good in terms of some of these issues. So although sometimes we walk away from them, but some way we socialize our children can give them a lot of mileage on good health. And if a parent doesn't know how to socialize their children, then you are giving, they are starting at a slightly less good foundation to be healthy.
We are going to come back to the role of you as an individual in making sure that you keep away from need for care. Yes. And today we are talking about universal health coverage in terms of cancer and palliative care. I know many of you may not know about palliative care, but many years ago, almost now 25 years, palliative care was introduced in Uganda. And we are going to have a clip of Dr. Anne Merriman, who is the founder of Hospice Africa Uganda, on palliative care. We'll be back.
And not 4 anymore. It's 3 shillings per second across all networks in Uganda.
Make calls from Airtel to all networks at 3 shillings per second. Get to talk to anyone on any network anytime at 3 shillings per second.
Airtel, the smartphone network. Airtel is regulated by Uganda Communications Commission.
My first introduction to palliative care was when I saw the way people were dying in UK when I was at home for a few years. I was a consultant with the elderly, and I felt they were dying very badly, and I knew that Dame Cecily Saunders had started this in London. So I started to read up about it, and I started to teach it to everybody around me. Eventually, I went to Malaysia, Singapore, Nairobi, and then we had this vision for palliative care for everybody in need in Africa. We looked for a model, and we chose Uganda as the model for palliative care. Now, palliative care is something that doesn't just treat a disease, it actually treats the whole person and the family as well. So you have to think not only of the pain, but we also brought in affordable morphine, which they've been talking about. And we designed that in Singapore, where they didn't have anything for people dying at home. Now, 90% of cancer patients don't get any treatment in Uganda. They're at home, and they need help. And many of them can't afford to get to the nearest health centre. So palliative care finds them using volunteers. And then we go to them, and when they're able to come to us, they come to us. And we treat them, we get rid of the pain so they can think about all the other problems that are facing them, the financial, the social, the psychological, and particularly the spiritual problems that are affecting them. And all our teams now are trained in this, and they will talk to the patients, they will listen to their concerns, and we will help as much as we can. Our biggest problem at the moment is we don't have enough money to do all we know we really need to do for these patients, but we are still trying to get it done, and the Palliative Care Association and African Palliative Care Association sprang from our roots, and they're doing wonderful work. Please keep stressing the need for palliative care, because those people who never reach health services are suffering, and they are the ones, the poor and the suffering, that need our help so much, and at least we can bring them to peace before they die. And that's what we all wish for, peace, a peaceful death with our families, and that's what they want too. So let's try and give it to them. It's very affordable, it's very cheap. It costs about, what? It costs about 40,000 shillings a week to run that. Now, in hospital for a week, it's much more.
Welcome back. This is UBC U Health Chat. I'm Dr. Dungu, and tonight in studio I have Professor Freddie Sengova, who is educating us about universal health coverage. The video we have just watched is talking about palliative care, the kind of care that is given to patients with life-threatening illnesses. Any comment about how universal health coverage gets into this?
Absolutely. So from its definition is to look at providing care at all ages for all the needs that are required in the community. Of course, there are a few countries that meet all these needs, but clearly a big population at any one time is going to be having very severe illnesses. Those illnesses can also create a lot of pain, a lot of discomfort, but also stress within households, within communities, and the broader society as such. So at any one time, these are very important conditions to solve. As you know, almost every community in this world has a way it deals with these hardships. And the health aspect of this is particularly palliative care comes in to deal with that challenge. And so there should be enough services that can cater also for this group. Because if those needs are not taken, then we shall have a group of people who are left behind. So what UHC does is to ensure that all the needs that are required for society or for the people who are sick are actually met. But as you know, like for example, cancer is a very big area where government currently is investing. And we needed to be proud by what is happening at the Cancer Institute and several centers that they are putting up. I think a lot is coming up, and we are beginning to see a slowdown on export, for example, of foreign currency. We used to have almost $140 million spent taking people to
exporting
patients out to be treated, and of course many times, as you know, we receive them not necessarily in a better condition. Some of course do cure, but if this service is here, then we can guarantee that more Ugandans can afford. And that is the type of what UHC requires, that services gradually improve in number, but also meeting the needs in the community. But of course, Uganda is a poor country. The budget is still small.
Apparently poor. Okay.
Yes, the rate at which we can provide everything for all Ugandans is likely to be slower than countries that have money. Even in America, today's conference, as you heard, the minister saying he has spends almost $5,000 per person, but they are still struggling to ensure that all Americans get the basic care. So, but Uganda with about 53, almost, I don't know, so many times less, we also want to see that our people enjoy good health, like Americans do. Because this is a health right. It's a right for everyone. But of course, governments have to provide according to their means. I'm not saying government is poor as such, but of course we are not in the same league.
You know, when you bring on that issue, I look at, and if I got you right, universal health coverage is comprised of much more than just health.
Exactly.
Taking steps towards universal health coverage means steps towards equity. What do you have to say, equity and universal health coverage?
Okay, there are two things. As I said, we all have to start by ensuring we are individuals, as communities, as households, as districts, and as countries, we do the best to keep ourselves in good health. That is the goal. Unfortunately, we don't have a good way to measure how we are doing. Every time there is no problem, people kind of feel nothing is happening. But more efforts are needed to keep society in good health. And we should be all investing individual effort, government effort, global effort to just do that. But when, of course, the question you raised about equity, many times you find that when it comes to, let's say, spraying household from malaria, you find the Kampala may be sprayed or Machindie, or but some Katanga here where mosquitoes are crowded are not being sprayed. When you see, for now, we are over 10 years rolling out like residual spray for mosquitoes in houses, where walls inside there. But we are still at 15 districts. If more, we are maybe in the 20s. We have 140 districts. So when will every district benefit? That's the equity issue. So if it is going to improve somebody's life or community's lives, how do we ensure that this benefit is really shared? We don't want to see some communities or groups of people left behind. If the cancer people can't get the care they need, or those who are end of life, they can't get the palliative care, they can't get pain relief, that is also important. yes, we want life dignified, even at the last minute of our lives. So those services which are required at that stage are also necessary. And this is what palliative care is all about. But also when we say health is a right, we are not just saying access care, no. We're saying please ensure that everyone keeps in a state of good health that they need to function, to be happy, and to be productive. And of course, when it breaks down, there should be a quick recourse without people having to suffer hardship paying for it. And that is the general definition of what we are trying to achieve in universal coverage.
Okay. The right to health is not necessarily the right to being healthy. We have a personal responsibility that we have to take to make sure that we do this. Now, we talk about minimum health package.
Yes.
How different is that from universal health coverage?
So they are actually related.
They are related.
Universal is partly to say, look, we should aspire to reach the goal that everyone should be healthy. But because of where we are as a society, and now I'm speaking about Ugandans, our means might just be able to cover a few core interventions. So we may need to, on that journey to get there, we should be taking priorities. Say, what is the problem now that we can solve so that the biggest majority of Ugandans can actually enjoy better health? Like I've just talked about malaria, we've seen that one of the big challenges for us to even provide that is to see that the quality we have of our health service is good. Nutrition is still a big issue in our communities. Children don't get enough to feed on and to actually get their potential. When mothers are having babies or pregnant, there are basic services they should get, and they should be of good quality. The midwife should be there. So when you look across the board, you see that there are things we are doing well as a poor country, and I want to commend government for that. Child health is improving very well. We are also working on the maternal health agenda very well. Epidemics management, we are doing very well. If you look at HIV, the curve is very nicely going up. So we can do some things, but we really need to start with those things that are basically holding us behind. But at this stage, we shouldn't be complaining about malaria. Countries have eradicated it. But when you look at how much our budget goes to these problems, which you can spray in a year and they disappear, for me, I think that we could do more with the little money we have. We could invest it smart.
We are discussing universal health coverage, and it's actually clear that you have a role to play to make sure that you don't even go to hospital. But for those who actually fail to do that, it's a big challenge. Cancer is a big challenge, and taking care of a cancer patient, whether you're rich or poor, you still will get poor. I've seen so many people who are having a good amount of money, and then by the time a patient gets to be treated, they are into serious financial hardships. So we need to make sure that we all have a role to play. I wanted to know something about, for example, Uganda's progress towards universal health coverage. Where are we?
You know, universal health coverage is not very different from what we've been implementing as primary health care, and of course we've had Millennium Development Goals, and we've had in this country a program trying to achieve what we've been calling other words, but it was all about how do we make health services available to the people, how do we prevent diseases, particularly childhood and maternal conditions. You will see that over the years, actually there are indicators which show that we made a lot of progress. When you look at WHO recent study, it tells us that if you look at a few tracers, about 7 tracers, Uganda is around 60-something% for those few services, if you looked at the health care from that. If you look at some conditions like I've already mentioned, for HIV used to actually be a death sentence in this country. Right now, people have even forgotten that was a problem. Because some people are even asking, can we see how a patient looks like? Because they are not there to actually say like we used to. I grew up during that time, and it was like our lives were cursed, but now
people ran away from clinical services.
Yes, so
because
I think
of
there's been some big changes. Right now, you see the hospitals are getting refurbished. We see the health workers are increasing in numbers, and you sometimes need to go to other African countries. I think Uganda, of course, we are always not. We always have to complain because the target is up there. But some countries are really. When you go there, you feel like, I think I better go back home. We are doing something good.
You mean the countries that we are better than?
Absolutely. On this African continent itself, I think Uganda should be proud that with a little money and all the challenges we still have, we are able at least to serve our people. If I can mention two figures, I think every year over 40 million people come to the health system for one reason or the other. We have almost 1.5 million children being born. That also means we have around the same number of mothers that need to be cared for. We need to immunize those children. And when you look at, when we say that our coverage our infant mortality or children dying before their first birthday or fifth birthday are all coming down, it shows something is happening. But of course, we really need to ask more of government. That is one set of service. We are talking of cancer. We are talking of palliative care. There are also so many, and these conditions have a unique need that I need to explain. Immunization, you get a jab. You may return 7 times to get a jab, but it's very quick. You get it, go home. But some of these are chronic conditions. The pain is so much. The treatment you need is for a long time, and it's very costly. As individuals, families will not manage. They will sell the land, they will get to communities, they will borrow, people will come in to support, they may not succeed individually. That's where you need now a government to organize and see how do we help these people. Insurance then can come in and say, what can we contribute together to help those that are going, because those needs are going to impoverish those who get them. I mean, those problems, those require additional efforts. But of course, if you can prevent it, we should be able as individuals to not just walk into trouble willingly. I've had people tell them, you read every packet of smoking, packet of cigarette smoke has danger signs. People continue to smoke.
They write them in English.
As if they, some even, I mean, some you don't need even to read their pictures.
You can see the picture.
But individuals say, me, I'm not going to be like mahogany. I have to die, I'd rather die. And sometimes this kind of, how do we help communities to actually not burden society with things that can be prevented, but also government, how can we focus our resources to big prevention areas where we can spend less but achieve more.
Now that you talk about government,
yes,
let's take a break with a video clip of the Honorable Minister of Health, Dr. Jane Ruth Acheng, to tell us government's position as far as palliative care and cancer care are concerned.
The vision of the health sector is to provide to ensure a healthy and productive population that contributes to social, economic growth and national development of this country. Uganda is currently undergoing a demographic transition, and as such, there is a lot of interplay between communicable and non-communicable diseases, which has resulted in an increase in conditions that require chronic care, like cancer. Palliative care provides the foundation of chronic care, and it is in this line, with this recognition, that the Ministry of Health specifically highlighted provision of palliative care as part of the wider National Health Insurance Scheme. Right Honorable Prime Minister, to date we have a full division for palliative care in the Ministry of Health, and we have created structures for palliative care in the human resource structure of Mulago, Kawempe, and Chirudo. And we will continue with this as the restructuring process goes on up to the lower levels. As you're all aware, Uganda Cancer Institute was chosen as a center of excellence for research and cancer care in East Africa. And it has undergone a lot of transition. Uganda is currently struggling to have all the necessary infrastructure for managing diseases like early detection, surgery, chemotherapy, and radiotherapy at the moment, and these are being addressed. Uganda Cancer Institute is in the process of bringing on board a linear accelerator to add onto the cobalt machines that we already have. I want to believe that there are plans to also bring in a PET scan, but that is for the executive director to give us the information. Regarding palliative care, since 1993, when palliative care was introduced in Uganda, the Ministry of Health has registered important milestones in scaling up palliative care services in Uganda. Palliative care services is available in 70 districts of Uganda. That means we still have nearly another 70 districts not covered, because we have 136 districts in this country. We have 11 hospices. Morphine, the drug of choice for severe pain recommended by the World Health Organization, is available in adequate quantities in all the accredited health facilities. Our regional referral hospitals have palliative care teams that provide palliative care services to patients who need it, and a substantial number of district hospitals have commenced palliative care provision. Some health centers have trained palliative care practitioners offering palliative care services, and this has helped to increase palliative care access and utilization. The Ministry of Health supported a number of clinicians, clinical officers, nurses, and medical officers through the Distance Learning Diploma Program to undertake the course offered at Hospice Uganda, and I do pledge that this support will continue.
Welcome back from the break. That was the Honorable Minister of Health emphasizing palliative care and cancer care. You know, in her remarks, she mentioned something on demographic transition.
Yes.
And many of us were wondering, what is demographic transition and how does it relate to universal health coverage?
Thank you. Yes, the demographic transition is about what government has set as one of the game changers for us to improve, to achieve the development goals.
Okay.
The government currently has in its vision 2040 to ensure that every Ugandan has at least $9,000. I think I would love to reach that.
$9,000?
Yes, every Ugandan, that's
Wow.
the goal. But of course, to arrive at that goal, there are a couple of things that need to happen. One of them is we have a population structure in Uganda right now where most of the population is actually young. If you cut it at around 15 years, almost 45% of the population of Uganda is under 15 years. Those people are not yet employed. We call them dependents. If you cut it at 20, we are almost 60% of the population is under 20. Again, these are people who are yet to enter the labor market, meaning that the other 40%, and if not even 40%, because some are beyond 60 and they are assumed not to be productive. So we have around 40% that are in working condition, working lives, like in the labor market. The rest of the population is actually depending on those. So I believe you and me are taking care of
so many people.
So many people. That is to tell you that our population needs to change. We need a transition where you have more people in the productive age group and less dependent. But that is a very big change, and should we achieve that, and with that have education, skills that are marketable, jobs that are available, and of course communities that are having enough income, then we can have what we call a population dividend, because more people are now working, they have few dependents, they can save. When you save, you can invest. When you invest, you can employ more people. Then the taxman will collect more revenue. Then it will go into roads, it will come to health, it will expand insurance. And that is called the demographic dividend. But that is one of the mechanisms government wants for us to realize the $9,000 per head in 2040. But that also calls for some discipline around how many children we can handle. As we know, Ugandans, we still aspire to have large families.
At least 6.
Yes, but you know, if you're going to have 6, that means you should really, the dependence is likely you and your wife are going to have a big dependence ratio. Chances are when you have 6, almost 20 years is locked up in having children and taking care of them. You'll never be as productive as you can be. So one way to even increase the years of production might be to figure out how much do you want to release your wife and yourself from so many dependency so that you can actually produce. And that is one key area where health can contribute, because if we don't, we are going to continue to have many needs, many children, many pregnancies, many childhood illnesses. UPE is going to continue to be a big burden. And if we have that, chances are we need to grow much faster if the population doesn't change.
But to me, I still think, you know, when you bring in this population dividend or demographic transition, we still have many people out there who still believe that let me have as many as possible, the government will take care of them. And I think that takes us back to what you said, that we all have a responsibility. She talked about investing in high technologies, linear accelerators, treatment modalities. How do these relate to achieving our objective of universal health coverage?
I'll speak about this in some positive way, but also where we have challenges with it.
Okay.
Clearly, when you are going to provide more and more services that the communities need, you are going also to provide high-end services. Where you need, for example, cancer requires some of the cancers require high technology. You need to diagnose using some expensive equipment. You need the specialized skills, and you need also people to come in for this screening. But if you can diagnose them quickly, you can treat them also quickly. And many of them could actually be able to be prevented from going into severe situation of cancer, for example. You need surgery also to cut some of these tumors before they become too big or spread all over. You need oncologists. Those are the people who know how to use medicine to treat the cancers.
Yes.
You need people who are going like palliative care specialists to deal with those who go into the severe forms of care. So all of this is saying that there are some investments we need to have at higher end. But how much can we go into higher end technology right now for all the needs is something that then brings me back. We definitely want to make advances, but the kind of monies and resources in the system, we would like to see that the basic things which are keeping the majority of Ugandans behind are actually focused on. That's the agenda around health promotion, prevention, because the simple diseases which are eradicatable are here, and yet other countries have done away with them. If we can deal with those, then we have more savings in the system. You have less money to spend on these malarias and the medicines that we have, millions and millions of cases every year. Then you can release those resources to start investing in the high-end technologies, in dealing with those complicated cases. But if the two go hand in hand, then we have a big burden still here which we are not solving, and we are introducing higher costs which we cannot afford to sustain over time. It's not enough to have something today and collapses tomorrow. And I think we still have those challenges. How do we sustain what we have. These equipment, as they come,
they need servicing, maintenance.
They take millions sometimes to be serviced, and you need to build the competence within the system to service them. And this, I think, is the kind of a balancing game that we need to. That's why government has put aside a roadmap to see what is it that should focus on now, and what should be the focus maybe in 10, 15 years. And we've been working closely with government to actually get a roadmap around UHC, which is a way of saying what should be the priorities now and what should be the priorities as we go forward, meaning that we can't do everything at once. As a poor country, we needed to stage them in a way that makes the well-being and the affirmative action around equity, equality achieved. And that requires that some conditions may get more focus in the short term, and others will wait a little bit.
Universal health coverage. We need a roadmap. We can't do it all at the same time. The community care. So we can do community, then we can do other levels of care. Is that part of the roadmap, or?
Absolutely. Actually, one of the big game changers in the UHC roadmap is what can we do, how can we do community health improvements better. Right now, you'll find that by the time we reach the community, we have trained very many village health teams, we call them, or village health workers. In the community, you'll find inspectors. In the community, we used to have a lot of health promotion. We used to have drug inspectors. We used to have sanitarians. Why I'm using the word we used to, we have actually lost focus on what should be in the community. Right now, we have more volunteers in the community. All the positions, almost 70% of the positions for health promotion to improve the health of the communities are empty right now. But the good thing, government has actually been listening. They've restructured. They've created a whole department for health promotion and prevention, which has not been there.
Within the ministry? Within the ministry.
Okay. To tell you that they are beginning to rethink. But of course, we now need to see monies and the designs of how to improve community health. You and me know, for example, palliative care, the best way to treat people who have cancer is to take care to their home.
Yes.
If you ask them to come 7 times a month, you're actually going to break them even faster. We see more protocols in this country for healthcare where you are required to visit the facility more and more times. For example, it used to be 2, became 4, now they're asking for 8 visits. Now, if you're a pregnant woman, you have to make 8 visits. Surely you are taking away time from your work.
And financial implications.
You are spending a lot of your money. The burden of costs are going to increase. So care has to focus in the community. How can we take health care to the community? How do we take health improvement to the community? So that this business of let them come to us, the patient, they are patients, they should come. And when they come, they should wait patiently. I think it's not the model we should encourage. We should be taking health workers to the community. I went to Cuba when I was very young and had the opportunity to move one of the previous ministers. What I learned in Cuba is that most of the primary level health centers there, they work up to around midday to treat patients. In the afternoon, they leave 1 or 2, the rest go to the community. They will know that Sengova lives in this home and has this problem. They will come with their medicine, they come and measure your blood pressure, and everything finds you there. Meaning they've actually moved from these people should come to us to actually go and keep people healthy in their communities. And that model, I think, is very, that's why Cuba, even right now, is not the best, the richest country in the Americas, but it exports health workers because it has very many people need, because the people
manufacture a lot.
The people live longer, they are happy despite not being so poor. So there are some models out there that inspire these concepts of universal coverage, but also where we needed to design our systems as poor people, to design them so that we deal with the problems at community level better than to wait for them to become big.
How are we going to pass on this message to the people in the community? Well, it's a good idea to go to them.
Yes.
But I still take what you said when we started, that if we keep away from disease, it's actually much, much better than that. And I know We've had people who discuss this. Right now, we'll go for a short break to hear what one of the main proponents of care has been, Dr. Jacinto Amandwa. Yes. He's been the commissioner in charge of clinical services at the Ministry of Health. He's currently retired, but he had this to say when we come back.
Money School Pay. Dial *185#, select option 6, School Fees. Select option 2, School Pay. Select option 1, Pay Fees. Enter student number. Enter the amount, enter the PIN number to complete payment. Beat the back-to-school hustle today. Pay school fees conveniently using Airtel Money. Airtel Money. Simple, instant, secure.
Airtel, the smartphone network.
Important thing in palliative care is that we should have access to everybody. And one time before I retired, I was in charge of palliative care in the country, and we set to implement the palliative care as per the WHO requirements. In fact, the success factor for palliative care are 4 items. 1, we must have good policies and support and political commitment. And during my term, the government of Uganda is very much committed to those. We have a good policy, we have a good support from the government right from 1993 up to today. We have got good collaboration in legislation in this country to allow nurses to prescribe, encouraging palliative care practice, and also availing medicines. The second success factor which we worked was human resource, education. Right from the beginning, the Ministry of Health, together with the partners, embarked on educating the profession of palliative care. And we have 3 main levels. 1, general knowledge for all health workers, which is being done, and also training nurses and clinical officers who can be palliative care specialists at the lower level. And number 3, introducing palliative care in health training institutions. I think that has helped a lot in strengthening palliative care in this country. The third success factor is availability of medicines. I must say, Uganda is one of the few countries where morphine is free. Morphine is a major drug for cancer pain control and symptom management. So the government of Uganda has been having free morphine. In fact, as we talk now, 100% of morphine is paid by government and manufactured, and it's very cheap. So that has been a big thing. And also either to that, the other drugs which are needed for palliative care, we ensure that they are on the certain medicines list, so they are available. Yeah, they might be changed, but they are generally available. The last one is an implementation framework, which actually government of Uganda has developed, and as commissioner at that time, I made sure it went into all aspects of planning in the government, not only in the Ministry of Health, but also in other aspects where palliative care can be of use. I think those are the major things which were done. A lot still remains to be done, and I think we should all contribute in our various capacities. By the way, palliative care is not only for health workers, and everybody must participate. And in my retirement, the government really calls on me once in a while to give them an advisory role, which I'm happy to do, and also to take care of the patients who are there, and also to encourage the other and advocate. I will continue to play my role as a palliative care person and also as a cancer patient. I have been with the cancer for the last 8 years, so I think there's something should be done. I don't want many people to go through the experience I went with. Maybe I was one of the lucky ones because I think when I got cancer, everybody cared for me. But there are not people out there who are as lucky as myself, and I think that I wish every Ugandan to have good access to cancer services and palliative care.
Welcome back. Indeed, everyone should have good care whenever they need it. I'm not saying you should have care for cancer But in the event that it happens, you should get the best care. Professor, we are almost coming towards the end, but you know, you talk about issues. We need to know, when you say about the roadmap, we need to know where we are going. Can universal health coverage be measured? Are there indicators for universal health coverage?
So the measurements, I think, are coming along. But what is important is to ensure that there is a workable framework on how we are going to make this journey. Right now, I've been privileged enough to work with government and then in the project that I lead with others called SPEED Project to really advocate for how to, but also advise on how to make this journey. One of the emerging consensus policy-wise on this matter is that we need to do a number of things, about 5 or 6 areas. One is we need to manage the population better.
Okay.
How do we ensure that people are well aware of ways to manage, to have children when they need them, and to be able to delay when they need to delay. And the issues of family planning in this country have been really contested, but I think we need to come to a consensus across all the leadership, both political, civil, and traditional. How do we help our country? Because this is a fundamental area of growth, as I said. The other one, we need to prevent things that we can prevent, illnesses. We need to promote better, and this requires that we work close to community. We needed to take programs in the community to ensure now people are exercising, they are eating well, but also they know how to manage their health. They know how to manage their fertility. They know how to feed themselves. They know how to care, because many of these require that we start there. But we also needed to take it to schools, but also to parents, to socialize children as they grow up, to know these basics. The education system needed to get people to know literally which is the lifestyles that are going to put you in trouble, which are the positive lifestyle. Culture also needed to bring those valuable behaviors and the norms that can help us to. The third element is we needed to provide those services that we've called them minimum, but give them at a higher quality, that people do not have to go and shop for expensive alternatives. We need to ensure that they are not too costly to impoverish them. The other one, we need to invest. Government, individuals, communities, we need to put money into health interventions, both prevention, promotive, treatment, and palliative, as we talked about. We also needed to work in partnership. These things cannot be done by individuals alone. Sometimes we want to work with leaders. We had leaders, the kakungurus of old, that used to ensure that you have a food basket that will take you through hard times. You will have a clean place to put your plates. You have a safe water source. Right now, the leaders even fear to actually hold the household accountable for these things, because they need votes. They don't want to penalize people to do the right thing. We really need to bring regulatory aspect that improve health. We need to go to water, to standards, to trade, to do their bit. Because if we have safe water, we can therefore reduce a lot of diarrheal diseases. If we have trade responsible, we don't sell all the food to Sudan because we are getting money. If we have safe roads, we also reduce. So we need to bring agriculture, we need to bring all other sectors that contribute to health to do their part. And with that, you realize that with the little money we have, we can make even more progress than possible. And of course, all this requires leadership, and I'm very happy that the media, particularly journalists, have taken on the health agenda very much. We have the private sector is also taken on the investment, civil society is there. This is the job that requires all of us to play their part, but also to hold each other accountable. If the other one is telling you, who have as many children, I'll give you a chicken, tell them whether the chicken is enough to raise a child. And the other, there are so many aspects where we need to hold each other accountable. And if we do that, chances are we will be able to achieve goals of UHC, and particularly keeping our Ugandans in good health at all ages, and no one is left behind.
As we wind up, in just a few words, what are your winding up remarks to our viewers on this important aspect of universal health coverage?
So universal health coverage, as we said, is one of the goals of government, but this, what is government, is what I want to end on. You and me are government, and if we start by acting responsibly, taking seriously our roles, and holding each other accountable for those roles, I think that we will be able, as a country, to not just dream about aspirations of having a health population that is productive and therefore can develop. We will actually live that dream. And of course, right now, the challenge is to turn that dream into reality. We've made progress, but there's a lot more.
That's what I wanted to hear, whether we are making any progress.
We've made this serious progress in this country, as I said. I think we are at a stage where you can say the glass is half empty, but of course that means it's half full. So we can continue to work on this road, and I believe we stand a good chance by 2030 to have at least demonstrable progress in this country if we all take our individual responsibilities and collective responsibilities. We'll get there.
I think that's a very good aspect, and I'll still commend you for that, to emphasize the fact that it is all our responsibility. Let's not put all the burden of our suffering to government, yet we also have a role to play to prevent this. I'm Dr. Henry Dungu, and my guest tonight has been Professor Freddie Sengova from the School of Public Health, College of Health Sciences, Makerere University. Thank you so much for coming to UHealth Chat. We're going to end our program here, and up next is going to be UBC Tonight with Patricia.
Was brought to you by
UHealth Chat is brought to you by National Medical Stores, who are mandated to procure, store, distribute essential medicines and medical supplies to all public health facilities in the country.
Three. What's up with number 3? It's 3 at Airtel and not 4 anymore. It's 3 shillings per second across all networks in Uganda.
Make calls from Airtel to all networks at 3 shillings per second. Get to talk to anyone on any network anytime at 3 shillings per second. Tuanzi Soze!
Airtel, the smartphone network. Airtel is regulated by Uganda Communications Commission.
Cottages Hotel in Rubaga. 7 accolades are for grabs in the following categories: documentary, sport and society, Olympic spirit, sports and disability, sports movies, sports advert, TV and weblog category, and a special award for the APL award. This will be given to an outstanding individual or institution that has served or contributed greatly in the world of sports broadcasting and cinema. For those interested in contesting, pick up entry forms at UBC Broadcast House, Nile Avenue, or call 0780-791344 or 0782-258152. Deadline is on 4th September. The winners in each category will automatically qualify for the World Final, the 37th Milano International Fix Fest 2019 in Italy, which attracts the best of the best globally. Join and let us celebrate culture through sport.